patients. These are the learning objectives for the next 30 minutes. That's first of all the mechanisms of gas exchange. Second, the basics of lung mechanics. Third, I would like to give you an overview about the mechanisms of respiratory failure. And last but not least, I would like to give you some hints how you can find out what's going on with your patient, particularly with the COVID-19 patients with respiratory distress if they present to the emergency department or the ICU. First of all, let's simplify the lung a little bit. So in general, we can distinguish ventilation from diffusion and perfusion. And in COVID-19 patients, especially in those who are critically ill, you often see that all three parts are affected by the disease. On the right-hand side, you see a normal alveoli. This is usually filled with air and has a very small surfactant layer, which is very important to keep the alveoli open. It has a basement membrane and epithelial cells. And within this alveoli, you usually find immune cells. In a healthy man or woman, you predominantly find alveolar macrophages. By far more than 90% of the immune cells in the alveoli are macrophages. And they are usually responsible for cleaning the alveoli. Then you have a very small interstitial, which is very thin. Otherwise, the gases could not go through this part of the alveoli. And in general, we may distinguish the conducting zone of the respiratory system, which is responsible from gas transportation and starts with the nose and ends with the terminal bronchoali, from the part of the lung which is represented by the alveoli, which is responsible for gas exchange. For gas transportation, this part of the lung, although not taking part in gas exchange, is very important for humidification of the air, for mucus clearance, and especially for immune defense. Since this part of the lung does not take part in gas exchange, we call this the anatomical dead space. The volumes which go in and out the lung during inspiration and expiration, we have to talk a little bit about some basics of lung function, which you can do in awake patients, but which you can also do with patients on mechanical ventilation. And to my mind, one of the most important points is that we have a certain tidal volume if we are breathing under normal conditions. For most people, this tidal volume is somewhere between 300 and 500 ml, and it is very much dependent on age, weight, and sex of the patients. Beginning with this normal breathing and with your normal tidal volume, you can do a very deep inspiration. And this volume, which is mobilized then during deep inspiration, is called the inspiratory reserve volume. If you expire then, until you cannot expire more, you have a certain volume which is below the usual tidal volume, and we call that the expiratory reserve volume. It is very important to notice that you cannot exhale the whole air of your lung, and there is a certain part which is always in your lung and keeps your lung open. And this part is called the residual volume. And together from the tidal volume, the expiratory reserve volume with this residual volume together, they are called the functional residual capacity. These 2 points are important in regard of mechanics of ventilation in COVID-19 AODS patients, since these capacities lower with more atelectasis in the lung. In regard of the airways, you always have a certain passive resistance. This passive resistance is physically dependent on the cross-sectional area. So this is something you usually cannot influence in patients, except you have some mucus plugging in the central airway. And although the central airways, trachea and the main bronchi have the largest diameter in our airways, they have the highest passive resistance since the cross-sectional area is much wider in the terminal broncholi and alveoli. So please keep in mind that if we talk about central airflow obstruction, we usually talk about the main bronchi and the trachea and not about the peripheral airway or alveoli. On the right-hand side, you have a typical flow curve of a patient on mechanical ventilation. In this case, it is not COVID-19. It is a patient with severe COPD. And if you look at the green curve, this is the inspiration, and here the expiration starts, and usually the curve should look like this. And in this case, you see a collapse of the central airways, so you can find it here in the flow curve. And then the patient needs a long time to expire. And this part of the expiration curve and of this flow curve here is usually due to a severe airflow obstruction in the peripheral air. This is a very typical case of severe asthma. And if you compare on the left-hand side, the acute asthma attack patient on mechanical ventilation, you see the central airflow obstruction here, and then the patient needs a long time to expire. 5 days later, after treatment, if you look at the flow curve, you see that the central airflow obstruction resolves. There is once more a much better flow in the lung, and the area over this curve here definitely improved during these 5 days. And as a result, you can see that the tidal volume increased from round about 150 ml to more than 500 ml. In regard of your COVID patient, I guess it's very important always to look at the flow curve of the ventilator and to have a look if the patient has enough time to expire and if there is any airflow limitation. So how do we get the air in and out of the lungs? So first of all, the inspiration and therefore the ventilation very much depends on the diaphragm and also to a certain extent to the intercostal muscle function. If you have a dysfunction in ventilation, the major result of it is an increased PaCO2. I guess this is very important to notice, since a dysfunction, of course, also leads to a decrease in oxygenation after a certain time. But the major result of the dysfunction is the PaCO2. Usually, our diaphragms move up and down in a range somewhere between 5 and 10 centimeters, very much dependent on age and weight, and also on having structural lung diseases or not. On the right-hand side, you see this typical dome-shaped diaphragm during expiration and during inspiration. And this is the important driving force to get the air into our lungs. Let me give 2 examples. On the left-hand side, you see a young man, very actual, with a COVID-19 infection. And if you look on the X-ray, you see this typical dome-shaped configuration of an intact diaphragm. And in contrast to this COVID-19 patient, on the right-hand side, you see a woman with COPD. And please notice this very, very flat diaphragm, which is not able at all to move up and down. And this usually results in a steep increase in CO2 and severe dyspnea. In contrast to inspiration, expiration is usually a result of the elastic recoil forces of the lung and the thorax, and is usually not done actively. You see that from time to time in patients with COVID, particularly in later stages of the disease, who try to breathe out and use their expiratory muscles, because in the late stages of the diseases, it might be that COVID-19 patients get a fibrotic lung, which increases the recoil forces of the lung and lead to more stiff lung. This lung stiffness can be measured, and this is important in regard of ARDS patient, but also for COVID-19 patients, particularly in the later stages if the lung gets stiff. And if we talk about stiffness of the lung, we always should talk about the compliance the lung has. We have on one hand side a static compliance. You can measure that in your patients on the ICU under very defined condition if the patient is intubated, if there is no breathing effort, and if you have no flow at the end of inspiration before the next expiration starts. You can simply calculate this compliance by dividing the tidal volume through the driving pressure. And driving pressure is simply the difference between the lower pressure level, which is called the PEEP level, and the upper pressure, which is called the plateau pressure. Very typical values of the respiratory systems in healthy lungs are around about 150 ml per minute, sometimes more. Intubated patients without having a lung disease typically show a decrease in the compliance if they are intubated, and it's around about 90 ml per minute. And in patients with severe ARDS, it decreases down to, let's say, sometimes 20 or 25 ml per minute. Let me give you two examples. These are two patients without COVID. On the left-hand side, it's a patient with moderate ARDS. And if you look at the tidal volume, it's around about 380 ml. And the driving pressure, so once more, the difference between the PEEP level, so the lower pressure, and the upper pressure here in this case is 12 millibar. And if you divide that, you will have at the end a compliance of 32 milliliter per millibar, which represents in this case a patient with a moderate ARDS. From time to time, and particularly in some COVID-19 patients, you see in later stages a fibrosis of the lung, sometimes a fibrosis which has no defined origin. We call that idiopathic, or sometimes in patients with ARDS. And this is a very typical case. If you look here, you have a tidal volume of around about 100 ml, and you have a driving pressure here once more of 25 ml, and the resulting compliance is only 4 ml per millibar, which in turn means that this patient is very prone to die because this ARDS developed towards a severe end-stage fibrosis. So how do the alveoli behave in regard of lung mechanics? On the left-hand side, you see alveoli in the healthy lung, which opens during inspiration, and once more, surfactant is the most important factor to keep the alveoli open, even if you expire. And surfactant helps your lung to avoid atelectasis and to be reopened with the next inspiration. In ARDS or in COVID-19 patients, the alveoli may behave different. On one hand side, you may have alveoli with a high resistance, so it's you need a high pressure to get air into this alveoli, and this may coexist at the same time in the same lung with parts of the alveoli and terminal broncholi with a low resistance. And also at the same time, you can have alveoli with a low compliance, so these alveoli are more stiff, and you can have alveoli with a high compliance. And as a result, it might be that you have some alveoli which open very fast, and on the other hand, you have alveoli with a high resistance which open very slowly. So in conclusion, in a healthy lung, you usually have in and expiratory time constants which are around about 0.8 seconds. which changes in patients with COVID-19 to alveoli with long and with short inspiratory and expiratory time constant. You may measure that in general for the whole lung with a pressure volume curve. On the left-hand side, you see that we have a certain volume of the lung still left. But with a completely closed lung. And you can compare that to a balloon. First of all, you need a certain pressure. Then the balloon starts to inflate. And if you put too much air in the balloon, this balloon will burst. Usually, even in severely ill lungs, you will not find bursting alveoli. But if the alveoli are hyperinflated, you will observe microtraumata which lead to the so-called ventilator-induced lung injury and is one mechanism why mechanical ventilation also may harm patients. Please notice if you deflate the lung once more, you need for the same volume much less pressure, which in turn means that you should never let the lung collapse. On the right-hand side, you see the same pressure volume curve together with the CT scan, and it's very nice to notice that you have many atelected areas here, and this atelectasis decreases with increasing pressure and also with volume in the lung. And you see that you have with very high pressures and with a very high volume in the lung that nearly the whole atelectasis, which is here in white, is now reopened. So now let's get from the mechanics of the lung to the gas exchange. And this is a typical scanning electron micrograph of a lung, which very nice show the acini and the alveoli structure of our lung. If you simplify that, you have an alveolar capillary membrane, and this membrane divides the air conducting part of the alveoli from the perfusion part of the capillaries of the lung. If you have a bypass of air conducting, which means that the air does not come into contact with the blood, we call that dead space. And if on the other hand, if you have a bypass of the vessels, which means that the blood does not come into contact with the air, we call that shunt. In a very simplified model once more, you see that the gas exchange usually occurs for CO2 and PaO2, which on one hand is released from the alveoli and goes into the erythrocyte, and in turn the erythrocyte releases CO2, which goes into the alveoli. And these mechanisms are usually very fast in the lung. We talked before about an inspiration time and time constants in the lung, which are usually around about 0.8 to 1 second in a normal lung. You see that most of the gas exchange is done very early within the first 100 or 200 milliseconds. The driving force of the gas exchange is simply the difference in the partial pressure of O2 and CO2 between the alveoli and between the erythrocyte. In regard of oxygens, I guess there are some essentials to know for treating patients with COVID-19. First of all, the oxygenation very much depends on the diffusion and not on the ventilation. So if there is any disturbance of diffusion, for example, by increasing the interstitial, if you have an interstitial edema in the lung, it will be much more difficult for the oxygen to pass this membrane and to get into the erythrocyte. The oxygen changes in the body usually occur very fast, and most of the oxygen is carried in the blood in conjunction with hemoglobin, and much less is physically dissolved in the blood. The normal value of PaO2 is around about 80 millimeters of mercury or 11 kilopascal. It is important to notice that we have no oxygen storage in the body, which in turn means that usually the oxygen lasts in maximum for 5 minutes until the first cells start to die. And therefore, this is the very important time frame for resuscitation and the time you have to get oxygen into the brain. We have a certain relation between the saturation you can easily measure and the PaO2 you measure with the arterial blood gas analysis. And if you look at the relation between saturation and PaO2, it's very important to notice that you have in low saturation values a good correlation with the PaO2. But if the saturation goes above, let's say 93, 94%, you see that you have not a very good correlation with the PaO2. So saturation very nicely reflects the oxygenation status if the saturation is, for example, below 90%, but it does not tell you how much oxygen you really have in your body if the values are above, let's say, 92 or 93%. It's important to notice that the pH value shifts this curve. So in patients with an alkalosis, which is very seldom or which should be seldom on the ICU, the curve shifts to the left side, which means that even a saturation of 80% sometimes means that the PaO2 is only 30 millimeters of mercury. And on the other hand, in patients with an acidosis, like you see that typically in patients with exacerbation of COPD, the curve shifts to the right-hand side, and low saturation levels mean much higher PaO2 level than in patients with an alkalosis. In contrast to oxygen, the CO2 regulation in the body is much more complex. Some key information about CO2: the diffusion capacity is at least 10 to 20, maybe 30 times higher than for oxygen. And most of the CO2 is not dissolved in the blood, but it's bound to bicarbonate. And bicarbonate can release CO2, which is dependent on the carboanhydrase, which is the most important enzyme to get CO2 out of the bicarbonate. And as you can see here in this picture, most of the CO2 is stored in bicarbonate in our body. In turn, that means that CO2 changes may occur very fast, but they also occur very slow. And this is the major difference to oxygen. The normal CO2 values in the arterial blood range around 40 millimeters of mercury, which means around about 5 kilopascal. And in contrast to oxygen, we have CO2 storage in the body. And if you look at this compartment model, you have some compartments which are very rapid. For example, the blood compartment and bicarbonate you find in the blood. And on the other hand, you have slow compartments or medium compartments like the bones, which can release bicarbonate and therefore CO2 over time. One major point to treat COVID-19 patients, to my mind, is that alveolar ventilation is the major factor to remove CO2 from the body. And if you have to treat a patient with COVID-19, alveolar ventilation is very much influenced by the tidal volume on one hand side and also by the respiratory frequency. So if you have problems to get rid of CO2 in your COVID patients, first look at the tidal volume on mechanical ventilation if it is high enough, and it should be around about 6 ml per kilogram ideal body weight. And look at the respiratory frequency if it's high enough in patients without airflow limitations. and if it is low enough in patient with airflow limitation, which means that they have enough time for expiration. CO2 is also the strongest stimulus of the respiratory drive, which you can see sometimes in hypercapnic patients if they are still awake. In regard of the COVID-19 patients, we have not only CO2 as one strong stimulus of the respiratory drive, but we also have mechanoreceptors in the lung, which detect the stiffness in the lung and sometimes lead to a very strong stimulus of breathing. And this usually occurs in these COVID-19 patients in the later stages if the lungs get stiff. This reflex is called the Herring-Breuer reflex and is one of the explanations why patients with COVID-19 in later stages have very high breathing frequencies despite having a normal CO2 or even a CO2 below the normal level. In regard of PaO2 and PaCO2, the arterial blood gas analysis is the key to get to the origin of respiratory failure in COVID-19 patients. If you don't have a possibility to get an arterial blood gas analysis, you may also use a capillary blood gas analysis that sometimes works in some patients, but usually a venous blood gas analysis is insufficient to get the real information you need for your COVID patient. The formula to translate kilopascal in millimeters of mercury, by the way, is kilopascal times 7.5 to get it in millimeters of mercury. And to get to the blood gas analysis, let me show you 4 patients with COVID-19. The first one is a patient on the ward who is that sick that he needs 4 liters of oxygen per minute. And if you want to go through this blood gas analysis, you may start with the pH value. And with 7.51, the pH value is above the normal limit, which means that the patient is alkalotic. Why does that occur? The CO2 level is very low at 33. So this is something you see very often in this COVID patient if they present to the emergency department that you have a certain hyperventilation, which leads to the alkalosis and low CO2 level. On the other hand, the PaO2, even with 4 liters oxygen per minute, with 60 per minute, is a little bit too low, although the saturation is still 93%. Looking at the next patient, it's a patient with COVID and with sepsis on mechanical ventilation. The FiO2 is 0.6. And if you look at the blood gas analysis, pH level is a little bit below 7.37, which is here in our case the normal range, which means that by definition this patient has an acidosis. CO2 is within the normal range with 45. You see that the PaO2 is a little bit too low with 65, maybe a little bit more is better for these patients. In regard to your national guideline, how much oxygen you should give your patient, you see that the saturation is 92%. But why does this patient have an acidosis? It is not due to CO2. In this case, it's due to the lactate. And therefore, lactate is one of the most important markers in patients with COVID-19 on the ICU because it reflects the end organ perfusion. And with 4.1, it's above the normal range, which in this case here is 1.8 as an upper limit. Last patient with COVID-19. This is one of the patients with an hyperinflammatory syndrome. And this patient is very prone to die. Why? The pH level is very low with 7.1. CO2 is slightly above the normal range. Bicarbonate in this case is very, very low. The saturation with 86% also. But the most important point is that this patient has a very high lactate level of 21, and this represents an extremely severe shock And let me say that most of the patients with such a high level will die within the next hours. The last point which is affected in COVID-19 patients is perfusion. And perfusion is a very common problem in COVID-19, and to my mind, much more than in patients, for example, with the normal flu. And disturbance of the perfusion means that parts of the lung are still ventilated but have no perfusion. And in contrast to the anatomical dead space, which you cannot influence, you have in this case a dead space which results from a mismatch of ventilation and perfusion and often occurs in these COVID-19 patients. First of all, this is a case of a young man who has a fresh COVID-19 infection with high fever. He has a severe hypoxemic respiratory failure. Typically, the thrombocytes are normal. The fibrinogen levels are severely increased as the D-dimers are above the upper limit. And the major reason for it is a severe pulmonary embolism. You can see it here, and it's indicated by the red arrows. And this is very often observed in this COVID-19 patient and may lead to a severe hypoxemic failure. In contrast to this macrothromby, in COVID-19, we see some further vascular alterations with microthromby. And once more, here on the right-hand side, you see the microthromby in the interalveolar septa of a lung, which in this case leads to a complete occlusion of this small capillary here, which in this case then leads to increased dead space ventilation, since you see here that the alveoli is still open, leading to a severe ventilation-perfusion mismatch. The opposite of dead space ventilation is, on the other hand, atelectasis, and this also may occur in this COVID-19 patient. You see that you here have a lot of atelectasis, but you have still perfusion here in the lung. And if you simplify that, you see that you have no ventilation here, but that you have still perfusion of this alveoli. And this is called shunt, and this may occur at the same time in your COVID patient together with dead space ventilation. So how do you get now to the mechanism of respiratory failure in your patient? So if the patient presents with an acute respiratory failure, I guess you have first to decide if it's an hypoxemic or hypercapnic respiratory failure. Hypoxemic respiratory failure is very typical for COVID-19 patients, and they usually have a low PaO2 and a low saturation, and CO2 is often in the beginning low due to hyperventilation. Hypercapnic presentation is more or less seldom in this COVID-19 patient. It's more typical for patients with COPD, except the COVID-19 patient has a COPD or asthma. In this patient group, they usually present with a high CO2 and also with a low PaO2, but your leading lab value in this case is PaCO2. In regard of COVID-19 ARDS, there is a long-lasting discussion about the type of ARDS. In patients with the flu, for example, as you see on the right-hand side, you typically have a capillary leak in severe cases in the beginning. There's a lot of edema in the lung, in this case here very severe. You see this edema here. You have a very low compliance of the lung, and usually the patient responds to PEEP and have a good recruitability of the lung. These are the typical initial stages of ARDS. You sometimes observe that also in COVID-19 patients, but it may also occur that they don't have a visual capillary leak in the beginning. If patients with ARDS improve, you have a second proliferating phase, and the immune system starts to get rid of all the detritus you have in the alveoli. In some patients, and particularly you see that in the COVID-19 patient, you have a fibrotic phase with excessive repair processes, and as a result, the lung gets stiff, and this is very often not reversible and only sometimes respond to steroids in the later phase. Just one word to COVID-19 ARDS. There is a long discussion now if ARDS of COVID-19 is comparable to ARDS as we observed that before. To my mind, this is maybe more or less the same disease we observe since several years, for example, in flu patients, but the difference is that the COVID-19 patients have a better lung compliance in the beginning, that they sometimes not really respond to PEEP, and that they have more ground gas infiltrates without having capillary leak. But over time, they may behave in the same way like a patient with a more conventional ARDS as we observed before. So last but not least, some practical steps how you can find out what's going on with your COVID patient who presents to the emergency department. So first of all, what can you do if you have no technical support? To my mind, it's very important which clinical impression you have from your patient and the consciousness of the patient. If the consciousness is reduced, this may be an important sign of sepsis and or the severity of lung failure. It might be also that this is a neurological manifestation of COVID-19, but this is usually seldom. If you have the time, perform a short medical history. Did the patient have contact within the last days? Does the patient have fever? Some of the patients also present with a body temperature below 35 degrees. Please keep that in mind. Do they have this typical dry cough? And then it's important to know something about comorbidities because COVID is very much associated with these comorbidities. If you have the time and if the patient knows, it's always good to know the permanent medication. The most important point to my mind, without having any technical support, is to count the breathing frequency of the patient. And please be alert if the breathing frequency is very low, let's say below 10 or 15 per minute, or if the breathing frequency is above 25 and in more severe forms above 30 per minute, which is very typical for this COVID-19 patients presenting in the emergency department. And it might be that you see a COVID patient with a breathing frequency of 35 or 40 per minute, and that you have a saturation which is still above 90, but in fact the patient has a very severe lung failure and tries to get more oxygen by increasing his breathing frequency. If you have some limited technical support, the first point you should do in this patient is a peripheral saturation. And this should be at least above 90% to my mind, but this accords to your local guidelines. It may also be 92% or 94% in some countries. In COPD patients, we usually recommend as a lower limit 88%. If you have a low saturation, you should apply oxygen in these patients, of course. And once more, please count the breathing frequency after applying oxygen. This gives you a very important hint about the severity of the COVID-19 infection. The next step is measurement of blood pressure, which is an important sign of sepsis and should be also treated according to your national sepsis guide. Especially in this COVID-19 patients, consider hydrocortisone in septic shock or dexamethasone if you think of the recovery trial. In regard of the arterial blood gas analysis, you should perform in this presentation of the patient. It's always good to do a fast decision in regard of the pH value. Is it normal or not? Is the PaO2 level below 60 millimeters of mercury? Is your CO2 high and low? And particularly, does your patient have lactate, which represents a mismatch in the peripheral perfusion? If you have some more technical support, of course, it's important in this patient to get some basic laboratory values. And from our experience, it's important to know how many lymphocytes these patients have, the D-dimers, the fibrinogen, and also the antithrombin. And since some of these severely ill COVID patients have this hyperinflammation syndrome, ferritin is also a very important marker besides CRP and PCT and IL-6, if this is possible in your lab, to early recognize this syndrome. The chest X-ray can be performed very quickly, and in many patients it shows its typical COVID infiltrates, but it also shows you if there is a lobar pneumonia and a bacterial superinfection, whereas a pneumothorax is very seldom in these initially presenting COVID-19 patients. And last but not least, coming to the end, since COVID-19 is also a disease of the vessels, and since you find so many thrombi in the patient, if the D-dimers are above the upper normal limit, you should perform a contrast-enhanced CT scan after weighting the benefit against harm in patients with acute or chronic renal failure. And therefore, thank you for your attention.